For those of you who don't know Dr. Carmona, it is my pleasure to share with you his incredible background. Dr. Richard Carmona served as the 17th Surgeon General of the United States. He's a laureate professor at the University of Arizona in public health, health promotion sciences, and community environment and policy. He's a distinguished professor of public health, a clinical professor of pharmacy, practice, and science, professor of surgery in the UA College of Medicine, Tucson, and chief of health innovation at Canyon Ranch Wellness Resort. To share with you a little bit more background that you may not know, Dr. Carmona enlisted in the U.S. Army in 1967 and became a decorated Special Forces Vietnam veteran. He later graduated top of his class from the University of California, San Francisco, and completed advanced training in general and vascular surgery, as well as fellowships in trauma, burn, and critical care. He was recruited to establish Arizona's first certified regional trauma system and held leadership roles in emergency medicine and public health at the University of Arizona and in Pima County. While working full-time, he earned a master's in public health driven by a commitment to prevention and health system improvement. He also led the successful turnaround of the county hospital, eventually integrating it into the University of Arizona. Dr. Carmona spent over 35 years with the Pima County Sheriff's Department, including as a SWAT team member and department surgeon. A nationally recognized expert in tactical medicine and emergency preparedness, he is among Arizona's most decorated law enforcement officers. And as we have talked about in his background as Surgeon General, during his 4-year term, he focused on prevention, preparedness, health literacy, reducing disparities, and issued the landmark report on the dangers of secondhand smoke. Among his numerous international commitments and appointments, he also currently serves in an executive role, as I mentioned, at Canyon Ranch Wellness Resort. And we have a rock star panel here, if I may say. So each panelist will introduce themselves, tell you a little bit about their background, but I would also like to reference that in your folders, for those of you with us in person, you have a detailed biography of each of the panelists before you today. We are so honored to have with us inaugural Women in Medicine and Science Technology torchbearer, Dr. Valerie Schaibley, and Regents professors, Drs. Marvin Slepian and Todd Vandera. Dr. Carmona, it's all yours.
Tracy, thanks so much for the introduction. I'm not worthy of that, and now most people think I just couldn't keep a job. So I certainly appreciate all of that. And boy, am I honored to be here today with some of my heroes here. I often felt like this as Surgeon General when I lived and worked at the NIH and among government. And almost every meeting I was at, I was quite humbled that I didn't feel worthy to be in the meeting with people like this who are the great minds who move science forward on behalf of mankind every day. So this will be a fun time for me. And I want to pass it over now to Valerie and let them introduce themselves, and then Marv, and then Todd, and then we can get started on the discussion.
Thank you. Is it working? Yes. Thank you very much. I feel like I am the one very humbled and honored to be sitting with my colleagues here on this panel. My name is Valerie Schaibley. I am the Associate Director and the Research Director for the University of Arizona Genetic Counseling Graduate Program. I'm also an Assistant Professor in the Department of Cellular and Molecular Medicine. I've been at the university for about 9 years. I was recruited by Dr. Ramos, so very grateful for him bringing me here and starting me on this journey here at the university. My specialty is in genetics and genetic testing, and so I'm very much looking forward to your questions, and I'll turn it over to the next panelist.
Thank you. I'm Dr. Marvin Slepian, and it's truly an honor to be among giants on this panel. And I've been at the university for 33 years. As you heard, I'm a Regents professor. I wear many hats. I started my work many years ago as a kid, really, in basic science related to inflammation, molecular biology, and things like that, and started really as an immunologist in rheumatology. I went over a little to the dark side in cardiology. So day to day, I'm a cardiologist. I'm also an engineer, and I develop a lot of technology. So as it relates to today's discussion, I've developed a lot of the things like wearables and other technologies that we may talk about. I also run the innovation center called ACABI for the university, which is a university-wide innovation center developing new technologies to unmet needs. That may be a molecular technology, it may be a physical digital technology, it may be an implantable technology. Some of the things that I've been credited as far as developing have been the first biodegradable stent, some very novel heart valves, and then the total artificial heart, which I was involved in as a big team, but we finally brought it forward. The other interesting thing that I did in my career, which I think is very relevant here, is in the Innovation Center, we have always been keeping lockstep with where we're going. So we got involved with digital technologies. We're now very involved with biomarker technologies, but we're now very involved in artificial intelligence. So for at least 5, 6, 7 years now, we've been deeply involved in fundamental work on artificial intelligence. And that's sort of a generic way that I approach things, and it may be relevant to speaking here today, which is what I call multi-scale. We look at things from the cellular level to the organ level to the patient level, and then integrate that above to some of the cultural and societal things that Dr. Ramos spoke about. And related to that, I really went over to the dark side because for the last 10 years, I actually went back to law school, and I'm an attorney as well. But it's been very insightful because I've been appointed some federal commissions on artificial intelligence and things like that. So I hope I can comment on some of those things from that perspective because it's very interesting. And I'll stop there.
All right, I have to follow that. Well, I too am very humble. Is this one working? Yep, okay. And first, I just want to thank Tracy for inviting me and being a part of this wonderful panel. Ken, I want to thank you for that wonderful talk. That was awesome. So. But I, too, as you heard, am a Regents professor. I'm the chair of pharmacology in the College of Medicine here. I also took over a program that Ken used to run, the MD PhD program, and so I've been running that for about 6 years, and I'm ready to pass it off to somebody else, Ken, by the way. So, but I also am the director of our Comprehensive Center for Pain and Addiction. I've been here for about 30 years now, and I've been working on the area of pain and looking at opiates. And believe it or not, about 30 years ago, I put out a paper that actually suggested that opiates could be dangerous. Yeah, nobody believed me. That was a paper that no pharmaceutical company wanted me to publish. But I did, and I've been on that track for many, many years, and I've worked at looking at integrative methods for helping people with chronic pain, and many of you probably have heard of green light, in which Dr. Ibrahim and I have worked on for some years, and of course Dr. Slepian has worked in this area. We're working on a protocol now to even look at how green light and music combine. Maybe some of you have heard that music also has been working. They've actually tried it in operating rooms and even prior to someone going into an operation and looking at how certain types of music can actually decrease the amount of pain after a surgery. So we're looking at other integrative methods, and another great area we've been looking at is also the use of cannabis products. Something I hope that actually comes up a little bit today. It's something that's very interesting to talk about, but looking at different types of cannabis products and whether it would be good for pain and inflammation. So anyway, I will hand it back and ready to answer questions.
Thank you, Todd. Where's Tracy? Did she step out?
I think she did.
Tracy, where are you?
She's in the back.
Oh, she's back there?
Tracy.
Yeah, there she is.
Well, I just want to, the reason
She's coming.
I wanted to embarrass her. I wanted to say that this doesn't happen by accident, and she is relentless as it relates to putting this together. I probably had a couple of dozen conversations with her, I'm sure all of the other speakers and many of you, but she is a force to be reckoned with as it relates to things, and just want to say thank you. Tracy, keep us on time, okay? Because we don't have a clock up here, and I want to make sure that... Well, that's what I'm worried about.
I'll be brief.
And before I get started, to Dr. Ramos, we still miss you. You had a very significant impact here, and in the rest of the country, you continue to do that. But we're kind of selfish. We're sorry you left us, but we're happy to have you back. So thank you for being with us. So let's start, before we get into the molecular. One of the challenges I had as Surgeon General was to take complex science and translate it in a culturally competent, health literate manner to deliver it to the population in order to effect sustainable behavioral change. So all of you are preeminent leaders in your fields, and you're educators. How do we make that translation? Just listening to Ken's presentation, most very well-educated people would be lost. They wouldn't have an idea. How do we do a better job of translating the power of this science to every person so they understand how to live longer, younger, happier, healthier, and cheaper? Let's start with you, Lisa.
Yeah, I mean, that's such it's such an important component of everything that we're trying to do. We can make all of these amazing discoveries in the lab and with integrating all of these technologies, but we need to make sure those are getting to the patients, that the patients understand what it is that's happening. My particular role with genetic counseling is really speaking to that in a very specific manner. Genetic counselors are really act as translators, taking all of this complex information, talking with patients and making sure that they fully understand what that is and how genetics in particular and some of these aspects of precision medicine can really impact their health. So from my perspective, I am trying to do this by training more genetic counselors. We have a significant lack of genetic counselors here, especially in Arizona. And so we're doing a lot of work to try and expand that workforce so that we have more of these healthcare professionals that are specifically trained in exactly what you said.
Perfect. Marv.
I'll go back to a kind of theme that I brought up, which is the idea of multi-scale. You have to explain to people on multiple levels and multiple different media outlets and other things. Let's start with the patient. I take care of patients. The basic dichotomy is what Dr. Ramos brought up, and that is that I have the patient in front of me. I have to understand and really get a sense of what their level of understanding is, what their level of interest and appreciation is. And then I, as the individual physician, you treat the patient based on knowing them. At the same time, we know the nuances, but we're giving them all the same stuff. So that's where this dichotomy exists as far as precision medicine. So by understanding what a patient can appreciate, know, understand, wants to know about, etc., I will bring into the conversation the utility of different aspects. If somebody's really hot on being the digitized self, then we'll talk about what device makes sense. Should I use my Apple phone? A big thing I get all the time is, my Apple phone, I'm an AFib. Hello? You're not an AFib. Your Apple phone is getting a bad signal. So you have to appreciate that. But if I have a patient who I'm glossing over, I'm not going to spend that time on that. On the other hand, the multi-scale, we as educators have to get the word out in the media, in publications, in symposiums, in events like this. And now the onus is you. You are now part of the team, everybody here, because you have to be amplifiers of what good science is about so that we get the word out. It's a diffusional effect that we all have to affect. I'll stop there.
Thank you, Marv. Todd.
All right. Well, I'll see if I can add anything else. Because I do quite a bit of teaching for the medical school here, is that one of the things that I love to do with the medical students is really sort of ask them direct questions. And I think when things become personal to each one of them, they actually tend to learn much better. So often we'll actually get into an example in which we will be talking specifically maybe something about some kind of medication that maybe their family member's taking or something that they're personally doing. And then we get into the details of sort of explaining how something like inflammation that Dr. Ramos talked about, how can that first of all produce pain? And it's so common to me the fact that when you ask somebody, we all know that inflammation produces pain, but when you ask them, how does it do this? This is where they all sort of stop and they look back at me and they think, well, I never really thought about that. I know that if I take Tylenol, if I take ibuprofen, it works. And I'm like, well, how? How do those things actually produce this? And so it's one of the ways in the model in which I'll take the fact that by asking them questions, it seems to engage them much more. And I think that's what I would sort of say to everybody, is that the best thing you can do is not so much talk as much as ask questions and then listen and then fill in the gaps. But that's what was one way that I like to actually sort of inform the public.
Thanks, Todd. I've been on the faculty, this will be my 40th year here at the University of Arizona on faculty. And I took a hiatus to go to Washington for a while, and I recovered from that. It took a while. But back in 2003, you heard Ken mention about the release of what was thought to be the end of the Human Genome Project. It really wasn't. It was the beginning, as Ken pointed out. But I had the good fortune to be at the table with Francis Collins, Dr. Watson of Watson and Crick fame, Craig Ventnor, and others when that was announced. And everybody turned to me and said, so how are you going to educate the public, Rich? And it became my issue. And so the first year, I just give you a little historical perspective. Francis Collins, for those who don't know, was the head of the Human Genome Project, went on to head the NIH. And the challenge for us then was, how do you take all this complicated stuff and get it to the average person so that they know, and we'll talk to their doctors and practitioners and such. So we did a one-year tour and hit all of the major medical societies, myself, Francis, the whole team that Francis had at NIH, to start the process of democratizing genomics to the average person. And that was over 20 years ago, and we're still not there yet, because it's gotten even more complex as it relates to the science. And one of the things that I had to learn myself was, how do I explain what a gene is? What's a chromosome? And what dawned on me, there were simple connections you could make. And I just give you an example before we go a little deeper. I said, well, a gene is just a software package. And so I started to tell people, what you all don't realize it, you're actually a computer scientist yourself, because these genes that are embedded in your cells are your software. You get 23 chromosomes from your mom and 23 from your dad, and you kind of act and look like them. Most of your life, you deny you're anything like your parents. And then when you get middle-aged, you realize, God, I'm just like them. But that was only the foundation. To the point that Ken made, all of those list of things that you do, which are called epigenetic inputs, they code your genes over and over and over again through your whole life. And they cause the genes to be expressed well or not so well, based on if you drink too much or smoke or sedentary or have a lot of stress in your life. So it's taken a couple of decades to get to this level that people understand that maybe the most important thing after your parents is what you do every day. So you are a teacher. You teach geneticists. What is it that you tell these instructors of the future as to how to engage their populations, the people that they have the privilege to serve, so that it is at the level of the average person, so that then it becomes actionable information?
I mean, I think it's using a lot of things that the panelists have already said. It's coming up with really good metaphors about these are computer software packages or blueprints, and putting it into terms that people can understand. But it's also asking questions and getting to know your patients and understanding who it is you're talking to and what their level of information actually is, so that you can convey that in a way that they can understand and really access. So I think it's incorporating all of the things that we were talking about, some of the things that Ken spoke about in his talk, is really trying to get at people's level of knowledge and how we can take this really complicated set of information and give it to people in a way that they can fully understand.
And Marv, so cardiologist and engineer, which most people would think are very far apart, yet they're kind of being unified more and more every day. Speaking with your patients who come in with heart disease, how do you make them understand the importance of this? But don't start yet. I want to put you on something else. But on the other hand, the importance of the engineering side of things that Ken mentioned as well, that we're not going to advance until we can figure out how to be able to capture that knowledge with an engineer embedded in this code that then benefits us. So you're right at the intersection of the science and the engineering that's needed.
You want me to give he told me don't talk long.
Not a dissertation.
So we're going to give a short answer, but
yeah.
Let me start sort of at what you brought up at the beginning. Actually, in cardiology, it's pretty easy, I must say, to explain the heart to the patient, because I always use the analogy, which people get, that the heart is like a car engine. You've got fuel lines, coronary arteries. You've got valves, you've got valves. You've got the engine block, that's the muscle, and you've got spark plugs, that's the conduction system. And that's it. So actually it's pretty easy. is we have an advantage because we have a common thing that people can all relate to, man, woman, whatever, child, they get it. We can draw it out. And I would say drawing is very important. I'm a big drawer, so draw things out that people can visualize. Now, how do we connect the dots down the scale to your genes and this and that? Well, of course, you know, sadly, bad cholesterol is an inherited thing for many people. It's not the only determinant of coronary disease, but and coronary disease is 50% of all of heart disease. So we have a winner in the fact that we have a genetic component to a major driver. And we also have, it's the leading cause of death, so it is the leading admission. So we have some pharma on our side in the sense that we have a range of medications. So it's a little bit easier. It's tougher for these more obscure diseases. If you have lupus, if you have Reiter's syndrome, if you have, you know, polyarthritis or some other complicated rheumatologic condition, it's going to be trickier to figure out how to do all that. I want to say one last thing, and I know you want to keep the conversation going. Back to your point, I think it's so important. You know, there's a generational thing. We grew up with DNA, RNA, protein. That's it, okay? Now we know it's a little more complicated and da-da-da-da-da, but that concept keeps being transmitted along. So the importance of education, of science education in kids that keeps moving forward. I'm not going to get into politics here, but I will just say that it's so important to keep the theme that science is important, medicine is important, and it has to go on in elementary education, high school, college, adult, senior. Everybody has to keep getting up to date based on whatever level of comprehension they want to have. And we need to have simple things to more complicated things so you have a nice, easy access to that. And that should be something that we want to put forward as a society, and I'll leave it at that.
Thanks, Marvin. I would ask Todd, you know, you're at the intersection of pharmacology and genomics, and it's everything from drug development to understanding how drugs act on the genes to enhance or slow down gene expression. Can you expand on that a little bit?
Yeah, so I think the most important thing to understand is that just about all medications will change genetics. So it's interesting to know that your genetics, and as Dr. Ramos points out so nicely, that we all respond differently to different medications. But medications themselves also, we know, will change genetics. So in other words, the continual use of different types of medications, I guarantee you, are changing your own genetics. And whether it's the genetic level or whether it's the epigenetic level, they actually will change. And what's interesting is that, you know, the human body adapts so quickly to something like taking ibuprofen or acetaminophen or any of the other types of medications, that eventually the body begins to change and adapt to those medications. And so it's not just that we all respond differently, let's say, to the medications, but your body's also going to change its response over time. And so it's one of the things that we often express, the idea that maybe a variation in medications is a good thing. Alternatives are a good thing. I want to point out the fact that even though we all respond differently to medications, and there's times where some people will say that they don't respond, whereas a person right next says, well, that drug works really well for me, as Ken points out. When we think about other healing methods, integrative type medicines, thoughts, breathing, that all affects us differently as well. So, and you think, well, how does that work? And the fact that we know that certain medications will respond through either their targets or how they're metabolized in the body, when we also do mindful thoughts, what are we doing? We're changing our own peptides, our own chemicals in our brains, whether it's dopamine, serotonin, cortisol, even some of the types of hormones. And what are those using? Those same receptors, those same enzymes. And so those methods that may work for somebody may not necessarily work for somebody else, but another method will work. So it's really a very dynamic, changing process.
It certainly is, and I think that it just brought to mind something else that's just been evolving that I'd like you all to comment to. Staying away from the politics, staying on the science. one of the things that disturbed me most recently when our colleagues at NIH and around the country who receive certain money for grants were told we're not allowed to consider the ethnicity, the color, and so on of a person. And the danger there is, we learned this decades ago, where up until a few decades ago, most of the people studied in pharmacology on how medicines work were middle-aged white males. And then you decided, then years later you thought, oh, well, it's not working on a woman. It's working different in a Hispanic and a Native American and so on. And the very diversity of the genome was being ignored. And so, you know, I hadn't thought about bringing this up, but when I heard your discussion, I think it's so critically important today, because just those decisions, for whatever reasons people would like to articulate they were done, could end up crippling pharmaceutical research, cardiology research, and education. Just those one thing. So how about you all comment in your own areas on the importance of understanding how diversity contributes to science and improving everything from pharmacology to clinical care?
You want me to do it?
Please, go ahead.
Yeah. Thanks for this question, because this is just a fantastic question. So only recently have we really started doing studies that have been trying to differentiate between male and female. So not even just different diversities, but let's just say between male and female, because everything, as you point out, has been done in the males. But just recently, within this last year, right here at the U of A, they have shown that the hormone prolactin that we all release, and everybody always thinks of it as a female hormone, but it is also released in males. And prolactin is, of course, a hormone that we most often think of if we had an infant and we're doing breastfeeding, but it does affect our whole bodies. Believe it or not, there's 2 receptors for prolactin. There's one that actually sensitizes pain fibers, and so it actually makes people more sensitive, and there's another one that inhibits. Well, guess what? In females, the prolactin one that produces more pain is at much higher levels and produces more activity, especially when you're stressed. It's interesting, as stress will actually cause the release of prolactin, and prolactin acts at the receptors that sensitizes the fibers. Now, in the past, we would have never known that, but it's been in the last year where studies have pushed the idea that we need to do studies between male and female to determine the differences, and is pain different. That is a perfect example in the fact that prolactin may sensitize the pain fibers in females, but not so much in males. And if you allow me, there's also something in males. You may have heard of orexin. Orexin is a peptide that our brain releases that keeps us awake. And a matter of fact, narcoleptics have a decrease in orexin. But orexin does the opposite as prolactin. In other words, orexin makes males more sensitive to pain, but not females. And so only those studies here at the U of A have actually been discovered, and we hope that as time goes on, we'll be able to develop medications that are specific for female and male, and then even get into the diversity, where you're starting to look at different ethnic groups and sort of say, what's causing sensitization of their pain fibers versus others.
Right. Just, Barb, before you start, you probably will hear the term receptor, and I just want to make sure that's just a place on a cell that a chemical can bind to. That's all it means. It could be a hormone, it could be a drug that was developed, but it's a place that exclusively accepts that stuff that's in your body, if you put it in from outside or inside. Marv, go ahead.
No, so I go back to what you, first of all great points here. I go back to what you said, and the idea of stay in your lane. I think politics should stay in politics. Science needs to stay in science, because they don't really mix. They mix in the way where if you can facilitate, it's great, but if you inhibit, it's bad, because now you're crossing over to the wrong side. When you gave the talk, and you talked about pharmacogenomics, instantly it popped in my head, the first study, because you're talking about it in today's world and the future and this and that. We had the privilege of having our paper being the #1 recognized publication. That was on the artificial heart in 2005 by the American Heart Association. Now, what was the #2? Bidil. Bidil was a common drug, which was a combination of simple nitroglycerin and other things in a longer form, that was shown to be much more effective in treating heart failure patients, the leading cause of admission to the hospital, in African Americans, not so much in Caucasians and others. We still use it, but we weren't using it there. It's not an expensive medication. Boom, we should be doing that. There are so many things. That's real medicine. We're taking care of those individuals. So pharmacogenomics has a big role across the board, needs to be further looked at in a better way for cardiovascular patients in a big way. Then you go beyond to the cultural issues that you brought up. Exercise, and we're talking about sort of these non-pharmacologic things. Music, light, color, sound, exercise. If you exercise, I'm sure you all know, if you go out for a nice walk and you have the sunny day and it's the wind blowing on you, you have an euphoric response. You're getting all of your hormonal elements and small molecule elements hitting your receptor elements that you just talked about, and you're getting all the positive responses. If I go for a run or a ride, I feel good. It's helping my heart because, sure, I'm stepping on the gas and running the motor. You know, cars don't do well if you keep them in the garage all day long. Your mechanic will tell you, take it out for a drive. So it's the same thing. Your joints, here we are with arthritis. If you exercise and you do stretching and you do all your things, you're getting the endorphin. I'll use that as a generic simple molecule that's causing all those improvements, reducing inflammation. So all of these elements need to be looked at. They need to be looked at in different cultural elements because, sure, there's an excellent thing I would tell everybody to watch, which just came out on Independent Lens, if you watch PBS. There's an African-American fellow who was a programmer for IBM, and it showed that at age 40, as he was about to be promoted as the only African-American in a completely white group, suddenly clutched his chest, went down, had a heart attack. He subsequently had 3 heart surgeries, and then he got it that maybe he should exercise. He went into a bike shop in a particular neighborhood in Illinois, and they looked at him as, why are you buying a bike? Well, that was the wrong approach. And he bought the bike, cost him $3,000, and at the end of the show, they talk about how he and his son rode from St. Louis to Chicago. That's 350 miles. And the big benefit and the diffusional effect that he had on that entire community to now get with it as far as changing the diet, becoming involved in exercise, losing weight, positive attitude, and the whole thing. So you can't deny the diverse elements in society, and we have to be able to address those in a positive way. I'll end there.
Thank you, Marvin. You mentioned some other epigenetic inputs. When we say epigenetic, anything out there externally that's going to affect your gene expression. And it could be the light in the building here, something called biophilia. You see the trees out here, and that, whether you understand it or not, actually has a positive effect on your genes. So many things that we took for many years that we just assumed were okay. When I was a kid, you built buildings, you wouldn't build it like this. They were dark, they had small windows, there was no good ingress and egress. This is a smart building. And the smarter buildings will actually, in the future, be able to recognize you by facial recognition and change the light, the sound, the colors, and everything to optimize your gene expression. Go ahead, Valerie.
Yeah, no, I just want to go back and thank you for this question again, because I think it's so important thinking about the role of diversity and how we understand human health. And because I'm a geneticist and because I'm a teacher, I'm going to explain one of these ways that we teach and how diversity is so important in that. So for a lot of the really common complex diseases, think about rheumatoid arthritis or diabetes, any of these really common conditions. We study the genetics of those using this technique called a genome-wide association study, where we're essentially looking at the people that have the condition and the people that don't, and the patterns of genetic variants that we see in those different individuals. And this is the underlying a lot of our understanding of the genetics of these conditions. And for many, many years, these were done almost exclusively in patients of white European ancestry. I think over 95% of the studies about 20 years ago had been done in these communities. And so when we started to look at how those genetic variants that we'd identified mapped to other populations, we saw that they weren't. What we understood about how genetics affects these complex conditions in white European ancestry individuals didn't translate over to others. And we've been making a ton of progress in the genomics community with trying to widen the diversity and understand the genetics of these conditions in more diverse populations. We've gotten better. I think it's more like 80% of the studies now are being done in European populations. So we obviously have a lot more room to grow in this area. We are certainly making progress, but these challenges that you were speaking about what kind of the politics is happening right now, we're in danger of at least having this progress be diminished a bit. So it's a very important question.
Certainly regressing significantly if we don't change that trajectory. Well, the other door I'd like to open right now is one that affects all of us in teaching or in clinical medicine. And I'll think back to when I was admittedly, I'm a recovering surgeon now, but when I was a real surgeon, and often taking care of injured patients or taking care of a transplant patient, and the issue of inflammation always came up. And when you'd explain to the patient what this was, I said, why don't you just make it go away then if it's bothering me? And the transplant patient says, why do I have to take all those steroids just because you gave me a heart or lungs? And if it's swelling, just stop that from happening and then I can keep my organs. But what they don't understand is if you eliminate all inflammation, you die. Because the fact is that inflammation is the starting point for everything, from new cells to old cells to healing to a scar. And the balance of attenuating the inflammation with drugs to let you keep your organ, and if you take too much, then what happens is you might be susceptible to infections. So we're walking this fine line all the time. So I thought, because of Ken's presentation and the fact that this is about arthritis, which is all about inflammation, let's talk a little about inflammation and how you all see it through the lenses where you work, the good side and the bad side of it. Why don't we start with you, Valerie? Go ahead.
I mean, I think, in genetics, I think there's a lot of integration of genetics into the study of arthritis and trying to translate that into the clinical space within the arthritis world and the entire inflammation world. I was doing a little bit of research because admittedly I am not in the arthritis world. And so I was trying to figure out exactly what genetic testing looks like in this particular world. And so it seems to be something that is very integrated into a lot of clinical settings. A lot of the things that Dr. Ramos was speaking about in terms of precision medicine, pharmacogenomics, things like polygenic risk scores, using a variety of different variants to help us understand our risk, is something that is starting to be integrated into clinic. And so I think the role of genetics in this space is just going to continue to grow.
It is. Before Marv, let me ask you, Ted, in the pharmacogenomic space, do you ever see a time where we would be able to truly attenuate, slow down inflammation, but yet still keeps the benefit of inflammation? That fine line we're walking, because right now we're coming at it with steroids. It's like a hammer, and you need a scalpel, for instance. Right. So where are we with pharmacogenomics and being able to somehow manage that inflammation so it's what you need positively, but not give you the immunosuppression challenges that cause us to have complications?
Right. Well, I still think this is the biggest challenge that we have, is trying to sort of say what is the right level. And I'll approach this from a little way that in the fact that when I do teach medical students, I teach about the pain, and I'm going to get to the inflammation, but I often teach about pain. And I tell medical students, I often ask them, is pain important? And of course they all say yes. They shake their heads. They're of course in their teens or 20s or whatever, and they're not in pain, and they're like, yeah, it's important. And so I say, but what about chronic pain? Maybe somebody that's had pain for 20 or 30 years, is this also important? No, we'll get rid of that. I'm like, well, how do you get rid of pain? So I always start out by the idea that there are, unfortunately, a few kids, now it's a very rare genetic disorder, where they don't feel pain, right? I don't know if anybody's heard about it. It's congenital insensitivity to pain. Those children don't live, unfortunately. because they can't feel pain, and eventually they have broken bones and internal damage and stuff to the point where they don't survive, unfortunately. And the only way to survive, and there was one girl, her name was Emily, who did survive. She was in Atlanta all the way through her college years, but she had a system, and her family created a system where 3 or 4 people were around her all the time. And if she ever fell or anything, they had to hurry up and tell the parents and then get her into a doctor because she wouldn't report pain. So, but I often stress the idea that pain is important, and it's exactly what, Rich, you're talking about, in that we have to have some pain. Now, I think most of you in the room would probably think, I don't want my pain, right? I want to get rid of it. There has to be some, because it's obviously a message to us, just like we have to have some inflammation. Some inflammation is very important for healing and for the process of cleaning up anything. But where do we get to the point where we want to know that we can decrease a certain amount but keep some? That's where it gets difficult, but it gets back to exactly what Ken talked about. We're only learning that there's 10 different macrophages, and I'll even tell Ken there's probably about 100 different macrophages, because the macrophages themselves express different proteins that then make them different. It's just like all of us maybe with different hair colors or different types of things. So there's 10 macrophages, but they will express different types of proteins, and those will change. The epigenetic and the change of those are based off disease, based off our treatments, based off maybe therapies. And so it's very difficult to sort of say we want to get rid of the ones that are causing the chronic pain and causing all the inflammation that's causing this ongoing, but we need to keep some to make sure that we survive, that we don't hurt our joints. A good example was the biggest pharmaceutical companies put out a drug. This was not a TNF-alpha, and it was the, I forget what, it was one of the big inhibitors for joint pain. I don't know if you've all saw this. It went into phase 3 trials. Many of the people didn't feel pain at all, so that was great, but they also didn't feel their joint. And they had all kinds of issues. The people felt great. They could never play tennis, but now on this drug, they went out, they ran miles, they played tennis, they ruined the joint. And so they had to go back into surgery, and they stopped the trials. And so it's a perfect example that we still don't have it. We're getting better and better, because the more, let's say, macrophages we find that we can try to eliminate but keep some is what really sort of we're going after.
Yeah, let me pick up on that. I mean, I think, there is what we call also the gift of pain. This is what David Armstrong, who used to be here, would always talk about. And it's the bottom line that, you need a little pain because it's a marker. It's a sensitivity thing to say, stop, be careful. And that's why diabetics who've lost that typically have lost that, and they develop terrible issues as far as damage to their legs, feet, and they ultimately wind up with ulcers and have amputations. So you need a fine balance. Second point, we will have a future where you're going to walk in. This is a little bit, sci-fi, but it's really not. And it goes to the last question that was asked when Tracy shut down your questions, which was the issue of what are the best biomarkers? And you're going to have a future where you're going to have proteomics, lipidomics, glycomics, metabolomics, all the omics in a smart card, which is going to tell you, here's your profile. And that'll all be integrated, can only be integrated, as Ken mentioned, with artificial intelligence, because there's no way any one doc will have the ability to keep all that in their head, and they may be having a bad day even if you have Einstein there. So you need a system to be able to do that. I think, as far as back to your original question for me, which was inflammation, I mentioned to you, I started in rheumatology. When I was a medical student, I spent 6 months. The NIH had a fantastic program in immunology, and I had the privilege of having Tony Fauci as my attending for 2 months in rheumatology, which was unbelievable. And I came to NYU, where I trained, to go into immunology, maybe rheumatology. Frankly, I wasn't going to go into rheumatology at the time because we didn't have anything to treat anybody other than steroids, and more steroids. So maybe I was going to do infectious disease. And infectious disease became AIDS. And one of my co-interns died from a needle stick. And so I said, maybe since I'm going to be a lab guy, maybe I should do something might be a little safer. And cardiology, everybody had heart disease. It was not a tough transition to go into cardiology because there was a common nexus, particularly for atherosclerosis, which is inflammation. And what happens? You build up a plaque in your artery over time, and then you get inflammation in that plaque. It's an inflammatory event, and then the plaque pops like a zit in an artery, and instantly you have a heart attack. So studying those mechanisms and looking, so we as cardiologists measure CRP, HSCRP, SED rates, all of that kind of stuff. But we realize it's way too generic. We need much more specific things. So we definitely, and we now know, what do we know about statins? I'm sure you're teaching this to your medical students. The pleiotropic effect of a statin is, it's an anti-inflammatory. So when everybody says, woo, statins, I don't want to take it, you know, it's bad. Sure, there are personal reactions to statins, and we check for that. But I tell them, the patients, that you have some positive benefit. If your CRP is high, let's track that. And the Jupiter trial in the New England Journal several years ago showed that Crestor, rosuvastatin, as compared to atorvastatin and the other statins, had the benefit of reducing CRP in addition to your cholesterol, so you're getting double bang for your buck. One more point, so I don't yak away here too much. Other drivers of inflammation. We know that if you have a big inflammatory load from another disease, it's going to drive cardiovascular events. We know that in the original influenza pandemic that occurred in the 20s, more people died of a heart attack than they even died of pneumonia, because subsequently they developed the inflammatory drive that then led to plaque bursts and people having heart attacks right and left. So the ability to tweak inflammation at the right level, we will have specific drugs that treat macrophages 3 through 5, but not 8 through 10, and that drop IL-6 but raise IL-8 or MMP9, whatever. All this stuff's going to happen in the future, and it's doable, but we need to keep pushing on with the science. So there are tremendous positive benefits of understanding inflammation. I'll make one last point. We did a big study. It was from here. It was on the cover of the Journal of the American Dental Association. And what we said is, you are as heart healthy or rheumatologically healthy as your teeth. If you had bad teeth and bad gums with periodontal disease and big inflammatory load, you had a much higher association of having worsening rheumatoid, worsening heart disease, etc. And if we just cleaned up your teeth, I won't get into fluoride in the water, but cleaned up your teeth, politics out of this, it would be very good as far as reducing inflammation. So you get the point. The hip bone is connected to the knee bone. Inflammation is central in all of this stuff, and understanding how we can get more granular and detailed in there would be great for the future. I'll stop
Thank
there.
you, Marv. Just a quick comment. Another term that's been tossed around is biomarkers. And for the clinicians and scientists, they know, but the biomarker is just a byproduct of a chemical reaction in your body that tells you something's going wrong. Where they're most important are not in arthritis, because arthritis hurts. You know you have a problem. It's in diseases that are progressing that you don't know. For instance, dementias, where a big area of research now is to look for the byproduct of that dementia so that you know that somebody is moving down that path before it's clinically relevant. So biomarkers is a big, big research area now in so many different areas. Last question, the last thing I would bring up, since this is about arthritis, and I'd like all of your comments. The average person thinks arthritis is one disease. My doctor told me I have arthritis. And as you all know, rheumatoid arthritis is different than osteoarthritis, and there's many other types of arthritis as well. So maybe from your own experiences, comment about the diversity of arthritis and how that's important that people understand that as well.
Sure. I mean, that's why I still do a lot of internal medicine. And I think that rheumatology, you know, as a field is amazing. And arthritis it's like me saying engineering. I mean, there's 50 different components. If you pick up McCarty or any of the old textbooks, you know, of arthritis, you'll see rheumatology. It's a complete diverse things. The beauty of what happened when I actually was at the NIH with Fauci was in the area of vascular components related to arthritis. They changed the categorization of arthritis, of the vascular components of this, from just anatomy to mechanism. It used to be you had big vessel disease, you had medium vessel disease, small vessel disease, and then it went to, well, you have disease which is related to cellular-mediated immunity or immune complex-mediated immunity or antibody-mediated immunity. In other words, they were getting much more molecular as to understanding of the nature of the diseases. These diseases are systemic. They affect everything. And that's why somebody asked that question in Ken, your questions, is how do you get doctors to really integrate? And I think that the onus is on us and everybody in the education, even of the physician, that medicine is, the concept of being a super subspecialist may be great for being that expert in that one disease, but I tell all my residents, and I've attended on the wards. I was chief resident of medicine at NYU, and I've said my proudest moment and what continues in my practice is that I still operate as the chief resident. I look at the whole patient as a whole. And that's the way to look at it. My father was professor of medicine, and he said to me, you have to, I'll tell 1 2-second quickie story. When I was a kid, I grew up doing all this really basic science, and I said it's DNA, and I was the kid who won the science fair and the whole thing. And I said to my dad, you know, DNA is the future. And he said, when a patient comes in my office, I need to look at the patient as a whole. He's not just his DNA. And I say that more than ever, and he was right, and I was wrong. And that's the way you have to look at an individual. So you have to integrate all of this stuff in a big way to really take care of the patient. So arthritis is systemic, and there are so many different flavors, and you have to be up on that to really be a good person in whatever you're doing. As a cardiologist, if you're not aware of that, you're not really up to speed. I'll end there.
Thank you, Marvin. Maybe in closing then, both for Tad and for Valerie, just quick comments on your experience. I mean, what reunites all of the arthritides is inflammation.
Yes.
But your own experiences with that and the public not having the knowledge of the broader definition of how complex arthritides are.
Well, not being an arthritis specialist, but what I would like to add is the idea that everybody's arthritis is different. Even though you get put into the category of rheumatoid or osteoarthritis, I would say that everybody's arthritis is definitely different. And in just even preparing for today's talk, what I've noticed when I looked at many of the different cytokines, ones that actually Ken brought up in his talk, like let's just take IL-6 for example. This one cytokine will actually alter many of the proteins that are even in your liver and your body for metabolizing drugs. And I think, well, why is that important? Well, if you have arthritis and you have higher levels of IL-6 or TNF for IL-1, each one of those are going to change a cytochrome P450. Now, maybe you guys haven't heard those, but these are the enzymes that are in the liver that they do a great job at sort of metabolizing everything that we put into our bodies. And then that would be food, but it also is our medications. And it alters that, and it alters them differently. So if you look at just IL-6, it actually causes a big increase in certain types of cytochrome P450s that tend to be more in the colon and actually may play a role in colon cancer. But then you look and you say, wait a minute, it also has a big effect on CYP3A4. And Ken knows this one. This is the one that probably metabolizes anywhere from 40 to 50% of all medications. That actually produces a huge decrease. IL-6 actually stops the cytochrome P450, or it downregulates it can up to almost 90%, meaning now you don't have the enzyme that's necessary to metabolize other medications that are most often used. And these medications can be any other types of medications, whether it's an antidepressant or whether it's a pain medication or other things. And so I would simply say the fact that arthritis is very different. We express different types. All of us, if we have arthritis, express different levels of cytokines, and those are actually changing how we actually respond to medications, but also to our diet.
Thank you, Todd. And we'll have a closing comment then from Valerie.
Yeah, it's just as my colleagues have been up here speaking and listening to Dr. Ramos's talk earlier, I think what has struck me is the power of precision medicine in arthritis specifically, because it is such a complex disorder. It's so unique to each individual person. And I really applaud Tracy and the rest of the center for putting this specific focus for this meeting today, because I think there's a lot of potential here for precision medicine to really make a difference in the lives of the patients with arthritis, integrating genetic testing, pharmacogenomics, AI, wearables, all of these different technologies into how can we best treat this specific patient in front of us, because everyone's experience is different.
Thank you, Valerie. And Tracy, I see you looming over there. So I will pitch it back to you.
You told me to keep you on time. So a tremendous, tremendous thank you to Dr. Richard Carmona and our amazing panelists. We truly cannot thank you enough. And we know that there are so many more questions to be answered. And we look forward to having you in the future with us at our presentations as we work to answer those meaningful questions. So we thank each and every one of you for being a part of the Arthritis Center family. Your support is invaluable to our mission, and your presence here today, online and in person, makes our vision and mission of community outreach and education possible. Our staff of clinician scientists treat patients each day whose journeys with arthritis date back decades. Some suffer from rheumatoid arthritis, others from lupus, gout, and so many from osteoarthritis, just to name a few. It is because of the leading-edge research, excellence in clinical care, and broad-ranging community outreach that the Arthritis Center instills hope in each and every one of these patients, and we couldn't do it without all of you. Our sincerest thank you to today's keynote presenter, Dr. Ken Ramos, and to panel moderator, Dr. Richard Carmona, panelists Valerie Schaibley, Marv Slepian, and Todd Vandera. As many of you know, it takes a dedicated team to organize an event such as today's symposium. A true debt of gratitude to our amazing team from the Arthritis Center and U of A Health Sciences. Greg Gillis, Yvonne Bello, Yvonne saved me this week, Gina Schwartzberg, Grant Gillis, and up in the control booth, to have a live stream with 550 registrants, it takes quite a bit on the technological side. So a tremendous thank you to Barry Bernard and Ricky Bergeron up in the booth. And with that, I would like to wish you all a wonderful summer. We look forward to having you join us when we begin our programs back this fall. Good afternoon, and thank you again for being with us today.